So, as per the WHO report 2024, hepatitis C virus is a major public health problem because it infects annually around 1.5 million new people that are positive for hepatitis C virus, and around 58 million people are worldwide harboring hepatitis C virus viremia. And so why it is important? Because hepatitis C virus infection, only around 15 to 45% of the infected people are able to spontaneous resolution of the infection, and other 55 to 85% leads to chronic infection. So this persistent infection and persistent hepatitis over the 20 years, 10 or 20 years lead to cirrhosis in around 20 to 30% of the patients, and this also lead to SCC annually 1 to 4% in patient with cirrhosis. So how to tackle this important problem? First of all, to identify the infected cases by adequate screening programs, to treat with highly effective treatment modalities, so that can prevent progression of hepatitis C virus infection to cirrhosis and related complications in the form of decompensated cirrhosis or SCC. So risk factors for progression of hepatitis C virus infections are well known: high viral load more than 5 logs, age more than 45-year-old, male sex, presence of obesity, presence of other infections like hepatitis B virus, HIV, significant alcohol intake and smoking. These are the risk factors that progress disease in patient with hepatitis C virus infection. So global burden of hepatitis C virus before the advent of DA treatment regimen, the estimated global prevalence was around 2 to 3. That was around 2 to 3% of the world's population was infected with hepatitis C virus. So this was higher in the underdeveloped or developing countries up to the range of 13 to 15%, and this leads to annual mortality around 3.5 lakhs of the people infected with hepatitis C virus due to cirrhosis and related complications. So as per the WHO estimate, Eastern Mediterranean region are the highest population that harbors hepatitis C virus, followed by Southeast Asia region, and around interestingly around 50% of the infected population are unaware of their presence of hepatitis C virus infection. So this study published in Journal of Hepatology 2014 showed that around 80 million of the people are infected, are harboring hepatitis C virus viremia, and predominantly this was seen in adult population, and less around 10 to 15% of the infected patients were in the pediatric population. The hepatitis C virus genotype 1 and 3 was the most common genotype reported in this study. The genotype 1 was more prevalent in the underdeveloped or developing countries as compared to the developed countries. China, Pakistan, Egypt and India was the most common countries that was responsible for more than 80% of the total hepatitis C virus globally. So prevalence of hepatitis C virus in SEER countries, that is Southeast Asia region countries. So this the WHO reported that this is around 0.5 to roughly up to 3% more prevalent in the countries of Thailand, Myanmar and Indonesia. From India, the reported study showed that variable prevalence from India from 0.5 to 4.7% depends on the risk behavior and state of the study. So this population-based study published in 2012, they screened around, they surveyed around 26,000 patients, door-to-door survey, identified the risk factor for hepatitis C virus in the form of substance use, prior surgery, immunization history, and other risk factors like IV drug abuser. So they screened around 5,000 patients and found that hepatitis C virus was positive in 5.2% of this population, and co-infection with hepatitis B virus and C virus was seen in around 5.9% of this screened population. So this another study from the state of Leh and Ladakh of 3,000 patients showed that hepatitis C virus they screened the patient for hepatitis B and C virus and found that hepatitis B virus was the main cause of viral hepatitis in around 12% of the patient in this population, and hepatitis C virus seen in just around 1% of this screened population. So this is the largest data from India, a synthesis of around 327 studies of this meta-analysis. They showed that studies reported from various states of India found that high prevalence of hepatitis C virus was reported from mainly from Punjab and eastern India states like Manipur and Mizoram. So as per this meta-analysis, the community-based this difference is mainly the prevalence is higher in the states of Punjab, Haryana, and more in the states of East India. This is because of multiple risk factors like more use of IV drug abuse, more use of unsafe needle practices, and also more repeated blood transfusions.
Good morning to all. So I will be presenting on non-invasive approach to stratify portal hypertension in compensated chronic liver disease. So why non-invasive tests are needed in these patients? Because the treatment of portal hypertension has shifted from bleeding centric view to a much more comprehensive view in form of prevention of decompensation, bleed, mortality, incidence of HCC, death. So it should be treated early, portal hypertension. This makes the use of non-invasive test as a surrogate of HEPG to assess the presence of clinically significant portal hypertension in patients with compensated advanced chronic liver disease, very attractive. So there are two terms, compensated cirrhosis or CACLD, compensated advanced chronic liver disease. Are they same or interchangeable? Well, Bavino 7 says that cirrhosis is more likely shows the histological term, is a histological term or pathological. So they use the term CACLD in presence of in place of compensated cirrhosis, though they are same. So LSM values by transient elastography less than 10 usually rules out CACLD. 10 to 15 are suggestive of CACLD, and more than 15 is highly suggestive of compensated advanced chronic liver disease. So why these cutoffs are taken? These cutoffs are taken from this paper, Peta et al. And they showed that patients with chronic liver disease and LSM of less than 10 by elastography have a negligible 3-year risk of less than 1% of decompensation and liver-related death. And 3-year risk of liver-related event increases substantially between 5 to 10 times with LSM more than 15, irrespective of CLD etiology. So this same paper, this figure shows that patient who has LSM of more than, that is a green one graph, it showed that they have cumulative rate of liver decompensation is higher as compared to the patient who has LSM of less than 21. So in patient with NFLD and compensated advanced chronic liver disease, baseline LSM and change in LSM, that is delta LSM, are associated with a risk of liver related events and mortality. So LSM should be measured at different point of time. So if you see this graph, this is a delta change in LSM. If the delta change in LSM is more than 20, that shows that cumulative rate of liver decompensation is higher. If it is also the rate of hepatocellular carcinoma, cumulative rate of liver related death and overall death. So this was the paper for the basis of Bavino 7 in the guidelines. So we have identified the cutoffs of LSM. So what do we do about it? So that was answer was given by the famous Predesky trial. This trial showed that patients which we have identified who have clinically significant portal hypertension with HEPG higher and LSM higher. So lowering HEPG with beta blockers could decrease the risk of decompensation in compensated cirrhosis with CSPH. The primary endpoint was the incidence of cirrhosis decompensation, and we showed, and this study showed that 20% patient had the primary endpoint occurred in 16% patient in patient with beta blocker group as compared to 27% in the placebo group. So this is the graph. Blue one shows the patient who were the placebo, and the endpoint, that is recompensation, was lower in patient who received beta blocker. So they have further stratified based on the child PUC score less than 6 or more than 6, and they showed that patient who were on beta blocker, they have lower incidence of lower liver related event or decompensation as compared to those patients who were on placebo. Similarly for the varices also, and HEPG more than 16 and or less than 16, the beta blocker group has a lower incidence of cirrhosis decompensation. Etiology was not that significant, so overall they showed that 27% had more risk of decompensation as compared to the beta blocker group. So only identifying transient elastography by fibroscan can be fallacious. So this Bavino also says that it should be correlated with the other markers of fibrosis like FIB4, ELF test, fibro test, or in patient of NAFLD or viral hepatitis. So this is an algorithm by Bavino 7 which shows LSM of less than 5 exclude CACLD or earlier compensated cirrhosis. 10 to 15 is suggestive of portal hypertension, and more than 15 is highly suggestive of CACLD, and more than 25 is clinically significant portal hypertension. So there is a rule of 5. Rule of 5 is 5, 10, 15, 20, 25. Less 5 to 10 exclude, 10 to 15 suggestive, 15 to 20 is highly suggestive, more than 25 is CSPH. Also there is a important figure of more than 20% associated with LSM of less than 20 or any decrease to a LSM of less than 10 is defined as clinically significant decrease in liver stiffness measurement. So there are invasive tests and non-invasive tests for portal hypertension. Invasive HEPG EUS, non-invasive includes platelet count, prothrombin, thrombocytopenia, von Willebrand factor antigen. Osteopontin CD163 is a fibrosis marker. FIB4 fibrosis marker along with FIB4, APRI, Fawn index, Locke index, ICG, ultrasound, CT, MRI, and LSM spleen. So these are the available blood tests which are AST to platelet ratio index and AST FIB4 same. So coming to performance of these different methods for predicting clinically significant portal hypertension. So prothrombin index has a with cutoff value of 82.5% has a sensitivity of 87%. Gyani score, which includes platelet count with spleen diameter, is had less sensitivity, but value should be more than 695. Von Willebrand factor of more than 241% has a high sensitivity of 85.7%, and Vitro score, which includes von Willebrand factor and antigen thrombocyte ratio, if more than 1.58 is sensitivity of 80% and specificity of 70%. Along with it, osteopontin had a sensitivity of 75, CD163. Locke index is AST to ALT ratio, prothrombin index, and INR platelet, and ICG contrast, ultrasound, CT, MRI contrast in T1 images. So I'll come to that. If we combine these tests, then we get the ELF test. So this study in 2020, non-invasive detection of portal hypertension was ELF score in patient with different etiology of advanced chronic liver disease. So ELF score and its component, that is TIMP1, P3, NP, hyaluronidase, were analyzed in 201 patients with advanced chronic liver disease, and all had HEPG of more than 6. So they showed that ELF and transient elastography, they fared same, and with ROC of similar, almost 0.83 and 0.834. With sensitivity, but sensitivity of ELF score was better with 81%, and the transient elastography, the sensitivity was slightly lower in this study. So in predicting the high risk portal hypertension by varices, the ELF score performed less as compared to the transient elastography. Same paper, the diagram on shows that ELF score and HEPG correlation. So it performed correlated well, but in patients with who had higher HEPG, ELF score was not that correlating. Similarly with TIMP1, P3NP, hyaluronidase. So hyaluronidase was important because it performed almost similar to the ELF score and in predicting HEPG as a non-invasive markers. So ELF and its component correlated with HEPG in the overall cohort, and the strength of the correlation between ELF and HEPG decreased in higher HEPG. ROC of ELF score to detect clinically significant portal hypertension was 0.83 and hyaluronidase level was similar as the ELF score cumulatively. So coming to liver stiffness measurement LSM in CSPH, so the basis of Bavino 7 was this study, Reberger. They included 502 patients with or without cirrhosis and decompensated patients also, and they concluded that 18 kilopascal was the cutoff for the CSPH. But further studies they included 30, 21, and 24, and the largest study was apart from it Hamilton study to 36 patients. So Bavino took CSPH for 25 in these studies and coming studies. So varices and screening endoscopy in patients that cannot be treated with non-selective beta blocker. They identified patients with compensated cirrhosis who are not candidate for initiating non-selective beta blocker for the prevention of decompensation should undergo endoscopy for varicose screening if LSM by transient elastography is more than 20 or platelet count is less than 150. Otherwise, they can avoid, and ELD endoscopy can be done if the transient elastography is less than 20 or platelet count is more than 150. So coming to another study in JHAP, prognostic performance for non-invasive test for portal hypertension is comparable to that HEPG. This study included 420 patients with CACLD, and they took anticipate NASH model vitro, which yielded similar ROC to HEPG gradient for hepatic decompensation within 1 to 2 years. So if you see that HEPG less than 10 or more than 10, the hepatic decompensation 7% with HEPG, and vitro model almost performed better than the HEPG 10.4%. Anticipate model was a 5.99%, LSM 6.4, and ASLD CSPH rule in cirrhosis was 6%. This was for 1 year, and they also did for the 2 years incidence of decompensation. And if we took HEPG as a baseline, then vitro test yielded better than HEPG in 16.4%, anticipate model 10.9%, LSM 10.1% in prediction of incidence of decompensation at 2 years. So at 1 year and 2 year both perform better. So this is the same graph that vitro tests were performing. This is a square one is a vitro test, and it is performing better than the HEPG or anticipate model in prediction of decompensation at 1 year and 5 years. So this is our study. Liver stiffness can predict decompensation and need for beta blocker in compensated cirrhosis. Patient with compensated cirrhosis with available baseline HEPG and LSM were followed for a median follow-up up to 26 months to determine the onset of clinical decompensation, and the optimal cutoff for LSM for predicting decompensation was identified and compared. They showed that the blue one, red one are the baseline LSM is the blue one, and the HEPG is the red one. So they were performing almost similar in predicting the decompensation as compared to the other marker of FIB4. So this was a time dependent area under the curve for 5 years, and this is very important graph. That this red one is patient with HEPG more than 10 and LSM more than 22. They predicted decompensation in the highest, and then there's a blue one is HEPG less than 10 but LSM more than 22. It was just next to the red one in predicting the decompensation. So LSM is performing better in the decompensation if HEPG is less than 10 also. So another study by application of non-invasive tool to decide the need for beta blocker for variceal bleeding prophylaxis in compensated advanced chronic liver disease. So a decision curve analysis. So blue one is the correctly classified patients of the patient who needed endoscopy, and this was the green one was misclassified high risk patient, and red one orange one was the misclassified low risk varices. So this was a retrospective study, and they categorized the patient into the different anticipate model, Bavino model, expanded Bavino, stratifier, patient platelet albumin and platelet MELD score, and they showed that at threshold of less than 3% event rate of variceal bleeding, Bavino 6 number needed to treat 176 platelet albumin and anticipate platelet criteria were superior, and they concluded that using both elastography and blood non-invasive test at baseline can accurately identify the need of need for non-selective beta blocker for varicose bleed prophylaxis in patients of compensated advanced chronic liver disease on follow-up. So coming to accuracy of point shear wave or 2D shear wave elastography in CSPH, so there are multiple studies which showed that cutoff was in the 88 patient point shear wave that 2.58 with sensitivity of 71% and specificity of 87%, they can identify the patient with liver cirrhosis. Similarly, for the 2D shear wave elastography, 158 patients study and 195 patients study, the cutoff was 0.86. 2D shear wave elastography, this Herman study, they categorize the patient into fibrosis 0, 1 versus 2, 2 versus 3 and 3 versus 4, and they showed that in all patient 8.25 differentiated from the fibrosis 2, 2 from 3 9.15 and 3 from 4 9.89, and it was also correlating with the different etiology of hepatitis C, hepatitis B and NAFLD related. So two-dimensional shear wave elastography performs better in patients with differentiating lower fibrosis or fibrosis 1 or 2 versus 3 and 4. So what are the advantages and disadvantages of LSM and spleen stiffness measurement for portal hypertension using the different available ultrasound elastography techniques? So LSM by vibration controlled transient elastography, that is affected by inflammation, venous congestion, infiltration, cholestasis, different cutoff, and indirectly reflects the portal hypertension. Point shear wave and 2D shear wave, they are confounding factors and etiology specifics. Success rate for spleen stiffness is low for the 2D shear wave elastography, and for the spleen stiffness measurement, the CONSAR measurement is not possible in some small spleen, that is, and use of Excel probe is needed for the spleen, and these are not validated also. So spleen stiffness can also identify the need for endoscopy apart from identifying the patient for clinically significant portal hypertension. Spleen stiffness measurement of less than 21, that rules out the CACLD, and more than 50, it includes the CACLD patients. In patients who are not candidate for non-selective beta blockers in whom endoscopy would be required according to Baveno 7, so LSM transient elastography more than 20 or platelet less than 150 correlated with the spleen stiffness measurement. They also showed that spleen less than 40 kilopascal by transient elastography can be used to identify those at low probability of high risk varices in whom endoscopy can be avoided. So patient with SSM of more than 50 is endoscopy should be done, and less than 40 they can be avoided and follow up in 6 to 1 year. So what are the disadvantages of spleen stiffness measurement? So two main disadvantages are, the first is high failure rate or around 15 to 30% that has been observed with SSM, notably with transient elastography and 2D shear wave elastography compared with the point shear wave elastography. The absence of splenomegaly, presence of ascites, obesity, as well as movements caused by the heart beating in case of 2D shear wave elastography negatively affects the success rate. So accuracy of SSM using ultrasound elastography techniques for CSPH and esophageal varices in CACLD. So they have used the they have identified the ROC of by the 2012 study 0.96, 0.98, 0.7. They all are performing better in patients with almost 260 patients, 200 patients with the higher ROC, and they have used different cutoff 46 like in Staffushno study 46, 40, 50. The highest, the largest sample size was the 2020 study, and they have used the 34 and 72 rule in and 42 rule out. So 40 was the basis for including in Baveno 7, which ruled out the portal hypertension. There are another study that used non-invasive splenic parameters for portal hypertension, and they used the splenic diameter and splenic area, and by using the splenic area and platelet count, they showed the ROC was 0.87 with 63% sensitivity, and splenic stiffness of 29 with platelet count, the ROC was 0.85 and sensitivity of 88% with specificity of 75%. So existing strategies based on non-invasive tests to decrease the need for screening of for varices treatment. Standard Bavino 2015 showed that patient who has LSM of less than 20 with platelet of more than 150, there is no need for endoscopy. Expanded Bavino LSM less than 25 or platelet more than 110, there is no need for endoscopy. SSM and Bavino 6, if they are included, and LSM is less than 20 a platelet, then there is no endoscope and there is no need for endoscopy. But if the SSM is less than more than 46, then endoscopy is needed. Similarly, for the LSM and the spleen assisted transient elastography. So the assessment of non-invasive markers for the prediction of esophageal varicose bleeding also. In this case control study, retrospectively they have identified 286 patients who are treated for esophageal varices, and they applied the ROC curve, and they showed that albumin with ROC of 70.73 and cutoff of 3.3 has sensitivity of 71%, and if they use the child-Pook criteria, then the sensitivity was 92% with ROC of 0.69 and sensitivity of 92%, specificity of 38%. So in this study, the albumin performed better as a non-invasive marker for prediction of esophageal variceal bleeding. Similarly, they have combined the marker also albumin with platelet count, where GP73, albumin platelet and CTP score, and they found the ROC was almost 0.75 with cutoff of 53 and sensitivity of 54% and specificity of 86% in predicting the non-invasive marker of variceal bleeding. So till now I have told you about the pathological or patients who had clinically significant portal hypertension, or LSM is more than 25 or 20. Now what happens to the patient who has normal LSM? So in patient, this study was done for patient who has LSM less than 6 and SSM was measured. They 70 to 30% ratio was used for the derivation cohort and validation subset, and they showed that SSM was 22.6 in patients and 22.6 in patient who has LSM less than 6. So 22.6 can be considered as a normal LSM, a normal SSM, and is comparable with the LSM also. In the derivation subset, the mean SSM for males was higher than females, just slightly, and we can see the distribution is better for the splenic stiffness, and they have included all the patients from 10 to 40. And if we see this graph, the derivation cohort and validation cohort almost coinciding, and they showed that SSM value correlated with the LSM in patient with normal LSM, and mean SSM in patient with LSM was 3 to 4 was 21, 4 to 5 was 22, and 5 to 6 was 23. And there was no difference based on age, BMI, diabetes or liver fat, and results were similar in the validation cohort. So spleen stiffness can be correlated with the liver stiffness in normal patients also, with the 22 value in patient with LSM of 6. So to conclude, LSM values by transient elastography less than 10 in the absence of other known clinical or imaging rule out CACLD. Between 10 to 15 is suggestive, and more than 15 is highly suggestive of CACLD. Splenomegaly, thrombocytopenia and SSM of more than 46 further increase the risk of clinically significant portal hypertension. Patient with signs of CHPH on non-invasive test should be started on beta blocker straight away to decrease the risk of first clinical decompensation, and the study has been done by Dr. Rahul. So way forward is we need to define the risk of decompensation associated with different LSM cutoff in different etiology of CACLD. Validate circulating biomarker for prediction of decompensation in all etiology. With SSM, define the risk of decompensation in different etiology. With LSM it is available. With SSM there is no study. There is no study on non-invasive test to define post-surgery decompensation risk also. In Bavino 7, they have used a MELD score of more than 16 to identify the patient who would decompensate after surgery. But we need to have the non-invasive test also. Also, non-invasive test to measure the beta blocker response in place of HVBG is needed. Thank you.